Good morning, friends. Thanks, Dr. Shroff, for inviting me for excellent session. My topic is tips to avoid such situation during primary surgery. Friends, we can see some factor which may later on lead to the subluxation because sometimes the condition is jonular dialysis, earlier dialysis, or minimal dialysis, we miss it. We are good surgeon, we have performed and we have put the lens. But later on, pseudo exfoliation, there are some factors. This can be early or late. Early, probably our surgical, some complication. Late, some differences or some jonular weakness. This can lead to patient severe as per degree of dislocation. As it is reported, it's 0.2 to 3% of patient after surgery has the dislocation and give the symptom like decreased vision, diplopia, glare, ocular plain. And everything depends on the extent of IOL shifting. Most cataract surgery preferred with no complication, IOL usually secured in the bag, but in high risk cases, chances of IOL dislocation are increased. These are previous history of trauma. It has not given the problem at the time of surgery, but jonules are weak and later on it can lead to the subluxation, pseudo-exfoliation, neuropathy. So evaluate all cases completely and discuss everything with the patient. It requires preoperative complete examination and you should take care of CCC diameter larger, chopping technique, so give to less trauma to the, in this delicate cases, less trauma to the nucleus or jonule and remove tangentially the cortex, so give less stress on the jonules. You can use the oil capture technique in weakened jonules, compromised PC or anterior capture of the optics, posterior capture of the optics. There are some of the situations you can avoid this decentration. Use of CTR in jonular weakness, suturing the CTR. Once you have put the CTR, CTR itself with the lens tilt. So you may need the suturing of the CTR. You have to select the IOL design, capsular contraction, single piece hydrophilic or three-piece hydrophobic. And sometimes you see the patient. This with the many times you come across. So if earlier you do the anterior capsulotomy with the YAG laser, you can prevent further dislocation and decentration in this type of cases. And OCT, anti-stomach imaging, this can detect preoperatively that you may going to end up in the problem. So it is a very helpful diagnostic tool for the posterior polar and sometimes a hypermature cataract, you may not be able to assess it properly. So it is one of the video where I assess the preoperatively, there is a large rent we try to do. So it is just to evaluate that what the situation, use the Rexis, a relatively good size, but keeping that size that if you may have to put the lens on the sulcus, so it should be good. With a staining viscoelastic, cataract was soft, minimal hydro delineation, aspirating the cortex. We are aware that there is the rent. Just remove your cortical aspiration. Will first aspirating. Then you need the good vitrectomy, triamcinolone. It will help us to identify the vitreous stag and good anterior vitrectomy. Now there is an option, either you can put that lens in the sulcus, three-piece, and either you want, if it is the putting this lens in the bag because we find that support was good, identifying the posterior capsule well and keeping that center. So it's taking due care. You can put that lens, you can put this, you can do the anterior capture of the optic. Then in cases of jonular dialysis, it is, you should suture that CTR well. Putting that CTR help us to stabilize. Then another important thing that we are having the good surgery. It is just many times we are using the injector and it's go with the jerk. It is in this case, it is created the hyphema, but many times if you go in the bag and it can rupture the bag and your all case, good surgery is turned into the bad one. Then you may end up break up the lens if you have not done proper assessment, the injected lens. So as mentioned, you can see that all this lens is completely broken. So sometimes, because it is so large, the lens, but sometimes small pieces or small haptics are broken, which is not go unnoticed, and later on it can lead to the degeneration. So you should be aware how to remove it. Cut that lens and remove it. Then you should be well aware with the iris claw lens. It is the safest surgical. It is the case with the subluxated cataract. But then if you will end up with the PCR and you're not able to, capsular support is not good, this iris claw is a very good option. You should be aware that you just hold it from this junction, and will prefer using iris claw instead of glued IOL or sclerofixated IOL because it is so simple.
Good.
Many times we are coming with the lens total back, as Dr. Shah mentioned, that total dislocation. This is the case because nowadays there are cases coming which have total, you are good placed very well lens in the back, but your journal support is very bad and the lens is dislocated with the full back. So here you should have the preoperative evaluation very well, that you can do the good vitrectomy and place the lens. Again the iris claw. And in this also, if you should be capture it well, because otherwise it can also dislocate. So you should assess that inclination should be good, and this type of the lenses will help you in security. Holding this at this junction will help. Then this repositioning, because that support was good.
Rajiv,
Capturing, because this 3-piece lens was in the anterior chamber, and so just dialing it properly, it will give it. So assessing your lenses after completing the surgery, its location will help. And this is one, what I was just saying, this is the case that this is the recently come at the case, one lens is dropped and another is showing. There is some problem. Already someone has done the yak capsulotomy, but still the lens is moving. It's a good vision, and other is. So this needs a handling. So in short, identify high risk prior to surgery, planning and plotting as per condition. Intraoperative careful steps should be taken, can avoid IOL dislocation. Thank you, sir.
Thank you very much. Thank you all faculty and friends. Thank you very much.